That's kind, thank you. Good afternoon, Mr. Gill.
Good afternoon, my lord.
Good afternoon, Dr. McKirdy.
Good afternoon, my lord.
When you're ready, Mr. Gill.
Thank you, my lord. Yes, the next witness is Michael John McKirdy. His witness statement references SCIWT 0148 and then 501. Dr. McKirdy, I think I've given you a full name, is that right?
Yes, indeed. Yes.
And as with all witnesses, you have provided the inquiry with a detailed statement of your evidence to us, and you are content that that statement is published, and also that the evidence that you give to us today in amplification of that statement is recorded and also published. Is that correct?
That's correct, Ms. Gale. There are minor typographical errors here and there for which I take responsibility, but there are two perhaps that we should correct,
yes,
if I can. At paragraph 22, on the fifth line, reads, the colleges were working with these associations to do work on the prisonisation. That should be prioritisation.
Yes, that's it.
And apologies for
I did have to look up what prisonisation was. There is such a word.
But that's not what I meant. And at paragraph 53, our patients in the Clyde catchment area are mainly in the Islands and Argyll, but it wouldn't be usual for us to patients from the Western Isles. They would tend to go to Inverness.
Yes.
So the Islands and Argyll.
Inner Isles, yes.
Yeah.
Thank you very much indeed for that. Now, you are president of the Royal College of Physicians and Surgeons of Glasgow.
Correct.
And from paragraphs 4 and 5, we can see that you became president in December 2021.
Yes.
And I think your tenure of office continues until December of this year, so a 3-year tenure.
That's correct.
Yes. And prior to that, you were president-elect from December 2020. And then prior to that, and as from the outset of the pandemic, you were, amongst other things, the Director of Global Health and Chairman of the Hope Foundation of the College.
Correct.
Could you just briefly indicate what the role of Director of Global Health involved?
So that's a good question, Mr. Gill. After the pandemic began, global health began to assume all sorts of different connotations, but up until that time, for those of us working in NHS Scotland, it usually meant involvement in the Global Citizenship Programme, by which we volunteered for projects in low and middle income countries. And the projects that we were involved in the college mainly were centred around Malawi and support for medical services in that country. So as Director of Global Health, I was responsible for those programmes of activity within the college. And I also had a role from 2018 onwards as part of the Global Citizenship Programme for NHS Scotland.
The Hope Foundation of the college, is that something different?
It is slightly different. It's a charitable part of the college which does raise money for our work in Malawi, but it also raises money for projects closer to home, usually in a medical charitable sense.
And I think we get a flavour of, obviously, the work of the college in the particular overview of the college's activities that you've given in your statement. And I think we can obviously take from that some of the roles that you would have in that those activities. So I think we'll leave that as is said. And can I just indicate at this stage that because of time constraints, and there is a good deal of substance that we want to go through in your statement, there will be parts of the statement that I won't touch on. But please be assured that the inquiry will be taking into account everything that's said in your statement, and will be utilising it as we progress further. Your own area of specialty I think, as you say, is that from 2017, you've dealt only with breast cancer surgery.
Yes, I've always specialised in breast cancer, but between appointment in 1997 as a consultant and 2017, I also had responsibilities, Lord, in general surgery and general surgical emergency work. But from 2017 onwards, my clinical practice was exclusively in the field of breast surgery.
Yes. And I think many of the comments that you make as we progress through your statement are either directly informed by your experience in the treatment of women with breast cancer during the pandemic, or are observations based on that experience that you can apply to other areas of surgery, I think
Yes.
would be correct in saying. Now, you have a section at paragraphs 16 to 20 of your statement in which you deal with the college's role as an educational and assessment institute. And we can again obviously read that section. That section has been passed on to my colleagues in the inquiry who are dealing with the implications of strategic decisions that were taken in respect of education. And on their behalf, there are one or two questions I've been asked to ask you specifically, but they may well come back to you in respect of other matters. But at this stage, just a few matters. At paragraph 8 of your statement, you refer to the work that the college does in relation to CPD and postgraduate work. And it's really the postgraduate work that I'm interested in. Is that internal postgraduate work, or is it in conjunction with other institutions?
A bit of both. Our main work would be working in partnership with the other colleges of physicians in the UK. That's the Royal College of Physicians here in Edinburgh and the Royal College of Physicians in London. On the surgical side of the college, we work with three other colleges in a conglomerate of four: Royal College of Surgeons of Edinburgh, Royal College of Surgeons of England, and the Royal College of Surgeons in Ireland. So postgraduate training, education and assessment in surgery is on a UK and Ireland basis, and postgraduate training, education and assessment in the physicianly specialties is done in a UK-wide basis.
Okay. Thank you. In the period of the pandemic, I'm sorry, let's go before the pandemic, pre-pandemic, were these postgraduate courses, if I can call them that, were they taught in person or were they taught online?
So mainly our teaching would have been in person. Yes. Prior to the pandemic. Some work would have been delivered online, and we had a suite of materials available to trainees which they could then access in their own time by logging in and accessing preparation materials for their learning. But most of our day-to-day postgraduate teaching and training would have been done face-to-face.
Right. And did that cease?
Yes, obviously, yeah, immediately. Yeah.
And when that ceased, did it go online?
Yes, yeah, I think we learned how to do that pretty quickly. Yeah.
Yeah. Did that cause problems?
In terms of teaching in a didactic sense of sharing information, not particularly, because we did have some online experience and it's easy enough to deliver that. So no particular problems with teaching. Clinical skills and clinical training were obviously impacted by the pandemic and the emergency that followed. It would also be, I think, important to note that there were some upsides of that teaching moving online, which was an expansion of our capacity and an expansion of an audience. And we've kept to that now some years later, and we use much more online teaching in order to reach audiences and save travel and so on.
And given that, I suppose, and considerable number of your students will have been overseas students.
Yes. Yeah.
I take it that a lot of the online teaching would have been recorded,
Yeah.
so that we could avoid the difficulties inherent in live teaching with time differences.
Yeah, and I think all of that we did, and we had done some before the pandemic. That was accelerated during it, and then we've been able to continue with the good parts of that since.
The students who, as it were, pivoted over the start of the pandemic, they had started their work with the college prior to the pandemic and then transferred to it being online. Did they continue to do so post the pandemic?
Yes, they will have done. I think everybody, as we recovered out of the pandemic, I think people were grateful for the opportunity to meet face-to-face and do more of the face-to-face type teaching and learning that we had been familiar with before the pandemic, but we've continued to deliver much online.
Was there any appreciable effect on attainment?
We've not found any evidence of attainment of knowledge. There has been an issue, which I think I allude to in paragraph 60 of my statement, about attainment of clinical skills. Obviously, perhaps the most obvious example would be around elective surgery. And during the pandemic, it was not possible to conduct major surgery, and the inquirer will be familiar with the impact that that's had on waiting lists in the NHS. In many ways, the waiting lists are obviously, sadly, people waiting for treatment, but they are also a waiting list of training opportunities for those who would normally be learning by being involved in that kind of surgery. So, for example, hip replacements. An orthopaedic trainee hoping to become an orthopaedic surgeon will have to have experience of hip replacement surgery. And because that kind of surgery was completely paused for a large part of 2020 and into 2021, obviously that experience couldn't be gained. Mm-hmm. So it wasn't necessarily a problem of attainment, rather one of attainment opportunity. So it wasn't that attainment was itself impacted. The trainees were perfectly able to attain knowledge and experience. It's just that that kind of experience was not available to them at that time.
Case of qualification delayed.
And delayed, yes. So training was lengthened for many people. So we have time, structured time for training, and most programs, they run over a period of years. And there's always been a possibility for trainees who needed extra time to be given that. But those trainees in that position obviously increased in number during the pandemic.
Was that resulted?
And I suppose from the individual trainee surgeon's perspective, potential deferment of promotion and therefore deferment of advancement of income opportunity.
I'm sorry, my lord. I'm slightly hard of hearing, so that's difficult for me to pick up everything you said. Sorry, apologies.
What I was suggesting was that the delays occasioned in training because of the lack of the experience opportunities would probably, I suspect, also mean delay of employment advancement, promotion to consultant rank, and therefore, no doubt, over a career, some income diminution for the surgeons involved.
I think that's a very fair point, my lord. I'm not aware of anybody quantifying that in any way to date, but there undoubtedly will have been people who will have been delayed in taking up consultant post because they were unable to attain all of their competencies in the time that they would have normally expected to. I think as trainers we tried very hard in 2021 to ensure that that was minimised as much as possible. And that did involve some trainees moving their training environment, for example, to take up opportunities. And one of the things we've been able to do at the surgical colleges is, for example, negotiate access to the waiting list recovery activities, some of which took place in the private sector as well as in the public sector, and to negotiate that trainees were able to gain as much competence, as much experience as possible, as quickly as possible, to try and minimise the impact that you described. But I think what you say is very fair.
Thank you.
Thank you, my
Mr.
lord.
Gill?
Thank you. I don't know, again, whether this is something that is measurable or has been measured, but has there been, either in the short term or in the medium term, an appreciable deficit in the skills that one would have otherwise expected in surgical work?
Not that I am aware of in any measurable way, Scale. I think there are always individual cases and anecdotes of somebody who would say, I don't think I've had enough experience. The NHS is a big, busy place, and I think the concept that we've had previously of the iconoclastic consultant surgeon who doesn't work as a part of a team is rather outdated. So anybody who perhaps had felt that they hadn't had the opportunity to gain as much experience of a particular procedure at the time of appointment would be functioning as part of a team and would have ongoing mentoring and support. So I'm not aware of that being a major problem in any of the common surgical specialties.
Thank you. Could I move to the section of your statement on public affairs, please? Now, prior to this, you've mentioned in paragraph 9 of your statement that the college plays a role in public policy, and in that connection, it has an ongoing interaction with the UK government and also with the devolved administrations, as well as other campaigning groups and influencing groups. And I think one of the areas you've mentioned is the area of climate change. You've also mentioned the area of minimum pricing, which I think is an issue that's come up today, I noticed in the news. In this regard, and having regard to the pandemic, you mention in paragraph 21 that the 4 surgical colleges worked with what you call the specialty associations in surgery to do work with the prioritization of surgery. Can you just explain what that involved?
So the group that I became involved in was organised by the UK Government Department of Health in London. It was a series of Teams meetings. The specialty associations, my lord, there are 10 recognised specialties in surgery, from general surgery, mainly abdominal surgery, trauma and orthopaedics, neurosurgery, ENT, and so on. And each of these specialties has a specialty association, which would be the recognised body for particular information within that specialty. And we worked very closely with them to look across the spectrum of work that would be in their specialty and work to try and prioritise the things which should be done no matter the pandemic carrying on, and other things which could be safely deferred at that time and would be better not done. And that was a fluid situation which changed through 2020, and then in 2021 as the population was vaccinated and so on, that changed. So we worked together and collaboratively with all 4 surgical colleges represented, with the government and civil servants to help us with that work, and with the specialist input of each of the specialty associations. So, for example, in plastic surgery, there was a very strong view that some of the more complex, time-consuming operations, which could be safely delayed with no particular outcome to the patient other than disappointment about delay, but there was no medical emergency for those surgeries to take place, would be in a different situation, for example, than the people within plastic surgery doing cancer surgery. So the cancer surgery would be prioritised, but more cosmetic type of procedure, and I don't mean by that cosmetic surgery, I mean by that procedures which people needed for good health reasons, but could be safely delayed, obviously with patient and to a large extent surgeon disappointment, but it was safer to delay those and to make the available space and prioritise those patients, for example, with cancer or more urgent conditions.
I think quite fairly on your part, paragraph 24 of your statement, you do acknowledge the demands that were placed on health departments and, well, governments in general and health departments in particular, but you also recognise the demands that were placed on clinicians. And it was in that context that you felt that it was important that policy work continued to inform the decisions that were being taken by government during the pandemic.
Yeah.
Is that correct?
Very much so, Ms. Gill, and I think, again, maybe draw the inquiry's attention to the fact that nobody had been in this situation before. There was no lived experience of dealing with trying to deliver in a longer term clinical care with the background of the pandemic, that nobody had any experience of that. And therefore people were placed in a difficult situation. Everybody was, population was, but within the delivery of healthcare, we had to work collaboratively with clinical leadership, but also with scientific input, with managerial input, and we also had to do our very best to work together with all parties. While there was a public-facing aspect for governments, there also needed to be a practical aspect of delivery of care, and that required clinical input. Yes. To some extent, it's very difficult to remember what things were like, wasn't it? But in 2020, our evening news looked like continued professional development for everybody, including the population. So we were all in a situation of new learning on a week-to-week basis, but everybody was aware of those responsibilities in my experience.
Right. You mentioned one particular area and one particular issue in paragraph 25, which is called aerosol generating procedures, or AGPs.
Yeah.
Now, one of the things we have heard a little bit about in the inquiry is concern, at least initially, that a view was taken, particularly by government in Scotland, that the means of transmission of coronavirus COVID-19 was by droplet rather than aerosol transmission. Was that something that was in mind when you became involved in, or your college became involved in, the aerosol generating procedures?
I think, again, for context, I think it'd be really important to say, I mean, I've worked in operating theatres since I graduated in 1985. I don't think I'd ever heard of the term of aerosol generating procedures until 2020. So, although we were aware that infection could be spread in aerosol and droplets, I don't think anybody practicing in surgery was particularly expert in any of that. We had to become aware of the means of transmission of a new disease. Again, that was growing information. I'm alluding back to these early months in 2020 when we knew very little about this virus, but we were looking at how could we continue clinical care. And at the very beginning, all that we did was emergency work, but then looking to try and find out if we could expand on that and begin to bring in other procedures to our work, urgent work. For example, in endoscopy, these are procedures to investigate symptoms in the bowel, either from the upper GI tract or the lower GI tract. We were aware of infection issues around endoscopy previously, and people were concerned, would these procedures in some way help the transmission of COVID? And so all of that work was, to some extent, to try and establish the facts, what could and could not be safely done. And in the early days, we left very long periods of time between operations in the operating theatre in order for the air in the operating theatre to be changed. Remember also in these first few weeks, we had no capacity to test anybody. There was no capacity to test the patients, nor to test the staff. So we didn't know who did and didn't have COVID. And there was, and again, I think it's pertinent for the inquiry, for me to remember back to those early few weeks, there was a sense of anxiety because healthcare staff, as the population did, people were dying of COVID and getting extremely ill with COVID. And nobody really knew that much in those first few weeks and those first few months about how it might be spread. So I think it's difficult to disentangle hindsight from how we were feeling at that time.
Yes. I think one of the things that you've mentioned already was the need to work collaboratively.
Yes.
And I think also you mentioned that there was a responsibility on the college to share and disseminate the information that it had within its membership to its fellows and members.
Yes.
So, again, can you give us perhaps a little some examples in the context of the pandemic that you were doing that?
So we were able to hold webinars for our fellowship, which were open to all of our fellows, many of whom work outside the UK. And these were webinars aimed to educate our fellows and members of what we were learning about COVID. So we were able to hold those webinars. We were also able to input to the webinars that others were holding. And so in my own specialty in breast surgery, we held weekly webinars at the very beginning to look at just how we could deliver the service in breast cancer. At the college, these would be more widely based around all medical and surgical treatment at that time and the learning around COVID. So this was to provide very rapid updates and almost in real time for our fellowship, and to encourage them also to take part in these kind of events run by their own specialty associations.
I think one of the points you've made subsequently in the section in your lessons to be learned is that perhaps one of the benefits on a positive side of the pandemic is and has been the increased use of collaborative working.
Without doubt, I think we're all aware that that period of time brought us all together, established relationships, and it's not that I wouldn't want to give the impression that everything in medicine and surgery prior to that was competitive and non-collaborative, but I think it's important to note that one of the positive outcomes of the pandemic has been an appreciation of working together across colleges, across the profession, working with civil servants and governments and so on to try and improve the outcomes and delivery of care. And I sense that that is still the case. And indeed, at a meeting here in Edinburgh only yesterday morning, we were expressing that from the 4 surgical colleges meeting together here, that we feel that there's a stronger establishment of collaboration than there might have been prior to the pandemic.
Okay. Thank you. Now, I am going to come back to your specialty of cancer treatment and surgery, because that is really perhaps the substance of your particular experience. But there are 1 or 2 other things I'd like to touch on before I do that. And first is PPE, which you mention at paragraph 61 and following. And you do say that in your own specialty you didn't have a specific problem with PPE at any point. But one of the problems, I think a number of problems that you do highlight, and one you've already alluded to, was the washing down of rooms and the doffing and donning of PPE in the context of surgery. Mm-hmm. Can you explain the implications of that?
So, if maybe it'd start in the outpatient department, it would be normal in an outpatient department for doctors to be wearing their own clothes, for no PPE to be used, and for the room to be tidied up between patients, but not necessarily every surface washed down. What we were then doing is between patients taking off aprons, masks, changing things. We didn't have a situation where we needed to wear eye protection in the outpatient department. But then every surface would be washed down and then prepared for the next patient coming in with putting on a new mask, a new pair of gloves, a new apron and so on. So there was a turnaround, just delay of not very long in an outpatient department, but significant. And also there was all the social distancing regulations about distance and so on. Mm-hmm. So our throughput was cut down a bit in an outpatient setting. In an operating theatre session, the PPE was more extensive because there was more exposure to body fluids, aerosol and so on, and droplet as we were discussing earlier. And so the donning and doffing of theatre gowns, masks, eye protection and so on was much more extensive. Not just cleaning the theatre as we would usually do pre-pandemic between patients, but also allowing these air changes to happen. So there were necessarily delays between patients, which were much longer than would have occurred pre-pandemic.
Yes. I think also that there are perhaps some more nuanced problems as well. In your particular area of specialty, but obviously in many other areas of specialty, being told that you have cancer, and particularly in the case of a woman being told that she has breast cancer, is a devastating experience. And one of the points you make at various points in your statement is the inevitable difficulty of displaying perhaps the necessary degree of empathy and sympathy if you're having to wear a mask. Was that a difficulty that you found in your dealings with patients?
Yes, I think all communication was made more difficult by the situation we found ourselves in the pandemic. Our environment had changed, as we were just discussing, and how we used even a familiar environment was very different. The clothes we were wearing was different. Patients were more anxious because they were aware they were coming to a hospital, which would have, in a hospital situation, would have held patients who had COVID. Our hospital in Paisley had temporary fences down the middle of the front hall in order to keep patient flows down one way and out the other, as we were all familiar with in stations and other public places at that time. So there was a slight anxiety of fear. So that's the kind of background. And then if you add to that people are wearing a mask, it means our communication ability as two human beings is compromised, because all we really have to go on is speech and our eyes, and you're not really seeing the whole facial expression of somebody. Also, we need to remember that in many outpatient settings, it was not possible for patients to bring in a supporter, yes, and they were often alone, so that would heighten everybody's anxiety. Yes. And I think in communication, we often think, and we did have to use the telephone, and I alluded to that in my statement, to break bad news on occasion, which was not something that would be normal practice pre-pandemic. I, in my clinical practice, will have told 2 or 3 women every working week that they have breast cancer. So it's something I'm very familiar with doing over many, many years. You're then trying to do this in a totally unfamiliar environment. And for example, to use the telephone, well, all we have is our speech and listening. But we don't have any sense of how the patient's looking, what their comprehension is of what we're seeing, what we're saying to them. The degree not just of comprehension of what we've just said, but also their level of fear and anxiety about what we've just said. Does something need to be repeated? Or would it be best to leave a pause? Or you're working rather literally in the dark because you can't see that patient.
Also possibly the level of understanding.
Yes, yeah. And so all of that was challenging and very challenging for patients and their families during that time. But I think we became very quickly conscious of that, and it's one of the things that we discussed was trying to adapt our communication to the situation we found ourselves in. I've alluded already, apologies, Lord Brailsford, my deafness meant I wear bilateral hearing aids, and so to have a mask hooked around your hearing aids was also uncomfortable and difficult and not what you were used to. And it meant my capacity to do a little bit of informal lip reading of what patients were saying was compromised because I couldn't see their mouth moving. So there are all sorts of aspects to our normal communication, and communication is a major part of all medical practice, but the breaking of bad news is a particular theme in all of that, and that's something which one develops skills and expertise in as years of practice go on, and that was disrupted by the pandemic, so it was challenging for everybody.
Yes. And I think you've also mentioned the requirements of social distancing
Yes.
and perhaps the inability to have a supporter there with the patient, and that was obviously something that would probably have been familiar to you pre-pandemic. In the course of the pandemic, was the position that a patient could not have a supporter with them, or was there a little discretion to be allowed?
There was certainly discretion in that. We obviously kept to the rules in terms of number of people in a room that was calculated for each room in the spaces that we used. But we were fortunate to have rooms that were big enough to allow 3, sometimes 4 people to be in a room. But again, it's the sense of disruption, I think, particularly in that first acute period, was difficult. We learned to manage it, but in a normal consultation, to meet somebody and go over the news about their breast cancer diagnosis, that would be normal for us to encourage somebody to bring somebody with them. Yes. So you would usually ask a patient if there was anybody they would like to bring with them, and if they said no, often you would probe that to say nobody else, maybe a friend or a neighbour or a family member, just to make sure there was somebody else there to hear what was being said and for them to check out that communication with thereafter. It would also be normal for us to have a breast care nurse in the room at that time in order to support the patient with a further conversation after the conversation with the surgeon was over. All of that kind of normality to our work, which had come to be part of common practice in cancer work over a period of 20, 30, 40 years, where we try to improve our communication with patients and their families, that was disrupted by the pandemic. And a bit difficult. And even a very simple thing, in my entire career, every outpatient I made, I would offer to shake their hand as an initial human contact at the beginning of a consultation, and to shake their hand again at the end of the consultation as an affirmation of my concern and relationship with them. That wasn't possible during COVID. So these kind of things had an impact on, I'm certain, patients, but they also had an impact on staff of being disruptive of normal work.
Might I, at the terrible risk of resorting to anecdote and also possibly the risk of giving evidence, which I shouldn't do, add my little bit there, and that is that from the patient's perspective, of which I have had some recent experience of, it is very important, I would suggest, that the patient is comfortable and has confidence in the treating clinician, particularly a consultant, and therefore exactly the touches you've just been talking about, shaking hands with the patient, is extremely important. And I would imagine if that were absent, doesn't make what is a difficult task any easier.
Thank you. I think that's well observed, my lord. Yeah. Thank you.
Thank you, my lord. You touched on staff, and I wonder if I can move on to the support of staff. And I think you're talking here about your clinical staff rather than the college staff.
Yes, indeed.
And I'm sure my colleagues in one of the other portfolios may be in touch with you about the furloughing of staff and matters such as that within the college. But can we deal with the supporting of staff? This is at you have this at amongst other places. You have it at paragraphs 67 and following. One of the things you talk about are staff well-being hubs, and that these were staffed by people who were not being utilised by the airlines.
Yes.
And I assume that they were being utilised within Glasgow Airport.
Well, no, the staff from Glasgow Airport, I think it was from a number of different airlines, but yes, they made themselves available and came to the hospital. And we used a vacant piece of space within the RAH to have a wellbeing hub, a kind of cafe type area. And it was staffed by people who were otherwise not working and presumably furloughed by their employers at that time.
What did they actually provide?
With tea and coffee, a space, where people could socially distanced be together, as it were, so you could still see that your colleagues were there. That was all I ever used it for. I think in different circumstances around the NHS there was the provision of food that was sometimes supplied by outside caterers who wished to do something for the NHS. There were a variety of people volunteering to help with the general well-being materials of somebody to talk to, well-being materials to remind people of how to look after themselves well during that time and so on. My main connection with them was getting a cup of tea or a cup of coffee, I would have to say, rather than anything else.
Okay. One point you make in paragraph 69 is that there was a concern, obviously, about junior members of staff and also trainees.
Yeah.
And I think you've mentioned the impact on trainees as well. The particular concern is that for the case of trainees who were from overseas,
Yes.
because they didn't have the luxury, if I can put it that way, of returning to their home.
Yes, I think we're very conscious, and this was something the college had a particular insight on. One of our key themes during all of this period of time put in place by my predecessor as president was about the well-being of staff and also of inclusivity. Many of our staff are international medical graduates who've come to train in the UK. They would not then have the normal family network necessarily at home. Some of them will have been married and with children here in the UK, but many more were likely to be living alone. Also, in a situation where they were worried about family members back home. And we were very conscious of that. For example, when you saw in the news reports of the impact of COVID in India, or which I can remember watching on the television, how things were there in Hong Kong and China and other parts of the world in Africa, we were very aware that that was a real concern for those people whose families were living in those countries. So I think they did need some extra support, even if that was simply a supportive conversation to say, how are things for you and your family and so on. But also aware of those who were alone, and that not necessarily only our international medical graduates, but anybody who was living alone, because we couldn't visit families, we couldn't go to our parents' homes, we couldn't go to other people's homes at that time. And so we're very conscious that anybody who was living alone, maybe their only other contact with anybody was coming to work, and so that should be a supportive environment, and we should be aware of their challenge and difficulties and be supportive to them.
Yes. I'll come on in a little to the mental health impacts, both on patients and staff. But just keeping on the matter of staff, paragraph 70, you say that overall, by the end of the pandemic, most of the staff that we lost were those who were coming up to retirement anyway. So if I can put it this way, the elderly, in terms of the working population cohort of nurses and other staff who did not come back after the pandemic, and you say they felt like they had had enough.
Yes.
Was that something that you were coming across as an expression?
Yes. And I think, as ever, these things are multifactorial, aren't they? I think it was a very traumatic time for people. Often, as people come to the end of their career, there will be a discussion, should they stay on for a bit? They've reached a stage in life where they perhaps could retire, but they're a little fearful of retirement and what that might mean. Should they stay on and work a little bit longer? I think COVID made people's mind up a bit more sharply across many of our staff groups. And for nursing staff, nursing staff of my generation would often have the capacity to retire in their late 50s because they'd started work in the NHS, often on leaving school at the age of 16 or 17. So as they came into their late 50s, early 60s, many of them would have had the financial capacity to retire. 2-3 challenging years of being redeployed across the hospital, of a lot of change of working environment. and also perhaps for all of us a sense that of our own mortality that we had been given by the pandemic, because many people lost loved ones during the pandemic. And so all of that would have added up to, I think, more people coming out of the workforce. And I think that's borne out by the statistics of the number of people who are economically not active but are in working age. And that's particularly for those people in their late 50s, early 60s.
Yes. Right. I'm brought on to the topic of mental health, as I think I indicated. In paragraphs 81 to 83 of your statement, you talk about that. And you begin with a general observation, which I think we probably heard from a number of witnesses. I'm interested to understand it from your perspective. You say, overall, it can be seen that the mental health of the nation was impacted by the pandemic. Can you explain, it may be something that's quite obvious, but if you can just explain your perspective on that, please.
So if on any one day you survey a large enough population of adults, you will find that somewhere between 15 and 20%, without necessarily knowing there's any disruption of their mental health, will be exhibiting traits of anxiety or depression, sometimes called common mental health disorder. So not necessarily a mental health issue which needs serious psychiatric treatment, but these days commonly known as mental health and often addressed in that way. That figure of between 15 and 20% of people who may be exhibiting traits showing their anxiety and depression, if surveyed, most surveys as we came out of the pandemic showed that that figure had doubled to something around 35 to 40%. So there's very clear statistical evidence from surveys that the background level of anxiety and depression amongst the population had doubled at that time. Mm-hmm. Similar surveys of staff in the NHS confirm that, and again that rate had increased. And there are deeper level studies looking into people exhibiting slightly more concerning behaviours, something that might be termed as post-traumatic stress, or abuse of alcohol or drugs, that those figures had increased during that time also. And those surveys have been carried out in the general population and also on NHS staff.
And again, given your specialty, you do say in paragraph 82 that one particular group that was impacted were women, and in particular young women. And you go on to say you'd run a clinic for many years, for a number of years, for young women under the age of 30 with breast cancer symptoms. Can you explain that and why you ran that clinic and what reflection you have on that post the pandemic?
So maybe to start by explaining why we set up that clinic in our service. We have very, very short waiting times for our clinical service, and that's been the case for very many years and has continued through the pandemic and still is the case today, I'm pleased to say. And one of the ways we've achieved these short waiting times is by being innovative in our practice. So we'd identified that there was a large increase in the number of young women being referred to our service with symptoms, but in fact breast cancer is a very unusual diagnosis in a woman under the age of 30. Only 1, possibly up to 2% in any one year of all of our patients diagnosed with breast cancer will be in that age group, and yet they'll make up 20 to 25% of all the women referred. And the reason is that young women have access, as we all have, I suppose, but are much more likely to look at social media and be familiar with symptoms and be health aware. And so more and more of these young women are being referred to us. In investigation of their symptoms, they will very, very rarely ever require a mammogram, a breast x-ray. And breast x-rays are a rate-limiting step for us in the delivery of outpatient services. So because of that, we could bring these women to a single clinic where we needn't have access to mammography, but had access only to breast ultrasound, and these patients could be seen by, as it happened with me, somebody senior and trained personnel working with me, and in the vast majority reassured quickly that they did not have breast cancer and that they had nothing to worry about. And so that was the purpose in setting up that clinic, and it's worked very successfully over the years. during COVID and subsequently, in the initial phase of COVID, for many of these women, we didn't see them at clinics because we simply telephoned them and told them that they didn't have anything to worry about by reading the referral letter from their GP. Some of the symptoms which they were worried about, they could be reassured, were not symptoms of cancer in somebody that in that age group. And so we deferred some of those people during that initial phase of COVID. Subsequent to that, though, I'm very conscious, because that's a subgroup of all the people I see, and as a breast cancer specialist, obviously most of my work is with women. I'm really conscious of the level of anxiety, and this is without me quantifying it in any way, in a scientific way, but just in day-to-day interaction with these young women, they are much more anxious than they were previously, and that's borne out by these population surveys that I referred to earlier.
Right, thank you. Obviously, for a woman who has been diagnosed with breast cancer, during the pandemic, if there was a delay in treatment, whether that be surgical or otherwise, that would increase that person's mental anxiety over the progression of the disease and the progression of treatment.
We did not have a major problem with that, Mr. Gill.
Right.
We quickly put into place alternative means of practice, which made sure that we did diagnose those women referred to us promptly, and that we were able to put in place treatment for them promptly. There are some, and I've alluded to that in my statement,
Yes.
there were some areas where we had to change practice, but to make sure that it was effective and timely was at all times our priority, and so we did do that. Perhaps one group that's worth mentioning, although it was a very small group at the very beginning, were women who were in the shielding group,
Yes.
who were referred with symptoms, and for whom it was safer. And I think I alluded in one to a conversation I had with a woman who was in one of the islands who was very concerned that she needed to come to the clinic, and we explained that she was better to stay where she was and have treatment with a tablet, which, if she did have breast cancer, as her GP believed that she did have, would be good and safe and effective treatment for somebody in her age group. And that's because many clinical trials over the years have shown that what's called primary endocrine therapy, taking a tablet to treat breast cancer, is extremely safe and effective treatment in women over the age of 70.
Yes.
So we already had those trials, as it were, from on a historical basis, and we knew that that was an effective treatment. And often, even in ideal practice, is the best treatment for an elderly person who has other comorbidities, making surgery unsafe for them. So it was safer in those first few months, was our national feeling and national guidance, to treat patients with a tablet without knowing for definite that they had cancer. Yes. And then, as we were able to bring them to the clinic a few months later and undertake their biopsies, prove they had cancer or not, for a handful they did not have a cancer, and they had taken a few months of a tablet to no great harm to them, no harm at all. But that was the safest thing to do, and so that was a national guidance at the beginning of the pandemic in 2020, and is a good example of a safe, effective means of dealing with the pandemic's restrictions on normal clinical practice to make sure that timely and effective care was put in place. Sorry.
No, that's very helpful. Thank you. Right, can we go to the impact on your own specialty now in a little more detail? If I can contextualize this, we note from paragraph 27 that you and your team of pre-pandemic 4 consultant surgeons deliver breast cancer service to around, on average, 375 women in an average year.
Yes, yeah. That's newly diagnosed patients in a year. We would normally be referred about 5,000 women to find these 375 women who had breast cancer. So we normally have about 100 referrals every week, and we would diagnose 375 or so women each year.
Now, the pandemic had an effect on the number of surgeons who were available within your team.
Yes.
I think you were halved.
Yes.
In simple terms. One was because of a surgeon being reallocated to general surgery.
Yep.
Another surgeon who was over 70 being shielded.
Yes.
And it became the situation, as I understand it, that you were operating from one place and your colleague, she was operating from, initially from the Nuffield
Yes.
in hospital in Glasgow, where there were surgical facilities.
Yes, the situation there was that as I think I've explained there, and hopefully clearly, was that our normal outpatient facilities in each of the hospitals from which we run our service, at the Vale of Leven in Alexandria, in Inverclyde Royal Hospital in Greenock, and the Royal Alexandra in Paisley, each of our outpatient departments was actually very close to the A&E or acute part of the hospital. And these areas were repurposed during the pandemic in order to keep the flow of patients who might have COVID separate from the patients who did not have COVID or did not have COVID symptoms, so that we could try and limit the spread of infection within the hospital as much as possible. So therefore our normal outpatients weren't available to us, outpatient facilities. However, handily, luckily, breast screening was also paused at that time. That is the invitation of women aged between 50 and 70 to come and have mammograms on a 3-yearly basis. And the facility by which that organisation in the west of Scotland happens for the breast screening service happens to be in Mandela Place in the centre of town. And so with the great help of colleagues working in Mandela Place, I was able to relocate our outpatient service to the centre of Glasgow, meaning that the patients coming from outside Glasgow in the Clyde area did have to travel into Glasgow to come and meet us in an outpatient setting. But we were able to repurpose the rooms there because the equipment we required in mammogram equipment and ultrasound and so on was already there. So the diagnostic part of our practice moved to Mandela Place.
Yes.
Similarly, for surgery, all of our acute hospital surgical space was taken up by those people who did have priority 1 urgent surgery, emergency surgery, and that was complex to deliver. We went from having 1 intensive care unit in Paisley to having 2 all the time, and a 3rd one on standby, which was only opened a couple of times. But we had to repurpose all of the staff at that time. So NHS Scotland, in effect, purchased from the private sector in different parts of Scotland, but certainly in West Central Scotland, they purchased operating time from the Nuffield Hospital, which had its own work temporarily stopped anyway because of the pandemic, but the theatre facilities were there. And so we worked cooperatively with people we were not familiar with working with, but my colleague based herself there and did the operating, and I saw everybody in the outpatient clinic, and we kept in touch by phone and Teams, and we carried on. And I didn't allude to it in my statement, but I think it's worth noting, if I may, my lord, we would normally have had a weekly meeting in which everybody involved in the care of breast cancer patients in our area would meet together, sometimes called a multidisciplinary team meeting. And so the specialist surgeons would meet with the specialist radiologists, pathologists and nurses, oncology colleagues, and we would discuss the management of a patient at a weekly team meeting. And that would have normally happened in a room like this, but within the first week or two we moved it all to a Teams meeting. Technology which we were very unfamiliar with at the beginning, but we were able to continue that multidisciplinary team management of all patients diagnosed with breast cancer from essentially the very beginning of the pandemic.
Obviously the journey from screening through diagnosis to treatment is a difficult and a long one.
Sure.
Just because you've given us within your statement a lot of detail about the that journey for women either with or leading up to the diagnosis of breast cancer. What, in your view, as somebody who is at the very sharp end of this, what, in your view, was the effect of the pandemic and the restrictions in the early days? So if we take it up to, say, September 2020, what was the effect on the treatment that you were able to offer?
So I think I've given a couple of concrete examples. So we had to change what we normally would have done. So we changed the protocols by which we would normally have delivered care. Good examples of that are with chemotherapy. Chemotherapy is very effective in particular situations in breast cancer, and for a normal cohort of women coming newly diagnosed, perhaps 15 or 20%, would be best treated by upfront, or sometimes called neoadjuvant chemotherapy, where their first treatment would not be surgery but would be chemotherapy. And the purpose of that chemotherapy would be to stop the growth of their tumour, shrink the tumour, and sometimes, in a number of cases, make the tumour completely disappear, be killed completely, and then have a more minimal surgical procedure. The problem at the very beginning of the pandemic, and it was a journey through those first 6 months, as you describe, was we were extremely concerned about giving anybody chemotherapy, because chemotherapy in a percentage of patients will make them immunocompromised in such a way that if they had been infected with COVID, they would have very likely died. And so we didn't use neoadjuvant or upfront chemotherapy in those first few months. We were still identifying those patients who in normal circumstances would have had that treatment as their optimum first treatment. But we're able to say to them, what we're going to do is not start with that treatment, but we're going to start with surgery, which is still effective and safe treatment. We will remove your tumour. We will get some further information about your tumour by removing some lymph glands to find out if it's spread and so on, and we worked out new ways of doing all of that. And then we will decide if you would benefit from chemotherapy. And in fact, relatively quickly through the first 3-4 months, by the time somebody's had surgery and recovered from surgery, there were perhaps small delays in people who would have had chemotherapy after their surgery rather than before. But we changed how we did the treatment. So it was still effective treatment, but it wasn't the position we'd got to pre-pandemic of what we would have considered to be optimum treatment. So that would be one example around chemotherapy use. And the other would be around the extent of surgery. So it would be, and been absolutely part of my clinical practice since appointment, would be that if any woman needed a mastectomy operation, we would try and offer her reconstruction surgery to mitigate the physical loss of her breast. It was not possible to do that type of surgery again in that early part of the pandemic because of the length of the procedure and the perception that there would be an increased risk to that patient in their post-operative recovery if they were to catch COVID at that time. Mm-hmm. And so we had to say to many of these women, this is something we'll come back to. It's not something we can offer you at this time. Our best advice is that mastectomy is still what we would have been doing. These patients would have had a mastectomy anyway, but it's just that the, if you like, mitigating extra surgery of having reconstruction, or sometimes called oncoplastic surgery, there are some other options around mastectomy and reconstruction around what's called oncoplastic surgery, reshaping the breast, doing breast reduction procedures, more complex surgery to the breast tissue. It was not possible to do that in those early months. And some of those women, it is important to say to the inquiry, will still be waiting for those delayed procedures because we've not had the capacity to get to all of them as yet, as we've come out of the pandemic.
Okay. So far as screening was concerned, what was the impact of the pandemic again in the early days?
The early days was
screening and in particular,
apologies.
Not at all. And in particular, given the geographic area that you cover, patients from perhaps some of the more remote locations that might either require screening or further diagnostic treatment.
So screening is, breast cancer screening is quite a difficult area to explain in terms of trying to give it in the inquiry there. In order to find 7 or 8 women with breast cancer, you have to invite 1,000 women to leave their home. So that's a big number in a time when we were in lockdown. And so the decision was made that the safest thing to do was to delay screening. The purpose of screening is to find tiny cancers which are not yet palpable, that is, they can't be felt. So the vast majority of cancers that are found through the screening programme are at the earliest possible stage before anybody could be aware of their symptoms. So that's what's meant by screening. It's sometimes a term that's used rather loosely about all breast surgery. So the breast cancer screening programme is just population screening, women between the age of 50 and 70 being invited to come for a mammogram. If you invite 1,000, roughly speaking, 700 will turn up. Of those 700, 35 will need to come back for further assessment, and of those 35, 7 or 8 will be found to have a cancer. is done on a population area by area basis, and it restarted end of August, beginning of September 2020. And so it was simply a pause of 6 months in finding these very early cancers. And it simply went back to its pre-programmed in our area of Clyde. The screening invitations go round our entire geographical area in a 3-year cycle. So whether you were on an island or a remote place, it would have made no difference. It simply was a 6-month pause. And so whether you were in central Paisley or an Isla, screening got to you, but in the beginning, 6 months behind schedule. My understanding is that that schedule has entirely been caught up now in the first cycle.
All right, that's interesting, thank you. We've perhaps in the discussion we've had so far focused on the period, perhaps the initial period of the pandemic. After that initial period, did things improve or appreciably, and in what way?
Yes, they did. We were able to go back to doing most things as normal. We returned to our own outpatient departments in Inverclyde and the RH in September of 2020, and we are still there. A slight sadness that we've not been able to start our diagnostic clinic at the Vale of Leven again, and that's due to a complex of different reasons about staffing and so on. It's not entirely attributable to the pandemic, but it's always difficult to restart something rather than keep it going. So our outpatient service is back to normal entirely. Our surgery is back to normal entirely, and our treatment protocols are back to normal. And that began to happen through 2021. I think the main reasons for that were the end of lockdown type restrictions, the vaccination of the population, widespread testing, which was then easy to manage, and we got better at managing the flow of patients who were diagnosed because we were able to return. We were able to return to giving chemotherapy as normal once people were vaccinated, for example. Once testing and once even the treatment of COVID had all improved during that time. Not my area of expertise, but all of the trials and so on were done at that time. Our treatment of COVID had all improved. So by and large, by the time we came to a year on from the restoration of services in September 2020, by the time we got to September 2021, almost everything was back to normal. We need to acknowledge that there are some women who are still waiting for the treatment they might have had, but in fact, for newly diagnosed women, there was no appreciable difference from then on in terms of their diagnostic or treatment journey.
I'm mindful of time, Mr. McKirdy, and I'd like to go to some of your observations because I think they're very relevant and, if I may say, quite pithy. If we go to lessons to be learned, so, which is at paragraph 84 of your statement, you do identify a number of positives that emerged out of the pandemic. And I think we've probably touched on some of these, and we can read what you say. The first being in relation to communication, and then the use of online facilities.
Yeah.
Which you gave a specific example of the use of online facilities, which hadn't been previously used, but is now used in your specialty. And you also talk about the collaborative efforts of your colleagues. But you do give an obvious negative impact in paragraph 87. And I wonder if I could just ask you to read that paragraph so that we do get the full impact of it from you.
Sure. Paragraph 87 is, I think there has been an obvious negative impact on the health service in that there was the decision taken to delay work that had to be done and to diminish our capacity to deliver that kind of work. This has left us now in a situation where it feels like for some people that this has left us with a problem which feels too big to solve. I think this is contributed to by a political gap where people do not feel that the UK or devolved governments actually have a capacity to deliver the restoration of the NHS, which we used to talk about in 2021 and 2022, when there was talk of rebuilding and restoring the NHS. I did many interviews with the media in 2021 and 2022 around the restoring of the NHS, and I worry now that I was perhaps too optimistic, because I fear now that people feel that this is too big a hill to climb. I think that we need to recover some of that spirit that was felt in 2020, that we had an issue, but if we put our minds to it, this is something we can deal with. I think this is particularly noticeable in numbers on waiting lists for the NHS. The impact of COVID on the ability for the NHS to deliver planned care has had a negative societal impact, and I fear that there is now, after the pandemic, a loss of faith in the NHS to deliver services.
Would that loss of faith, in your opinion, have occurred without the effects of the pandemic?
That's a good question, Mr. Gale, and an unanswerable one. I think it's reasonable to say that in a UK-wide basis, waiting lists for treatment had steadily increased from 2010 through to 2020. And the NHS's capacity to deliver planned care across all 4 countries in the UK had led to increasing waiting time for planned or elective surgery, increasing waiting time for outpatient appointments and for investigations, and it was measured in the acute service by the 4-hour wait in A&E. And during that period of time, from 2020 to 2020, invariably in different parts of the UK, one could see that the overall performance of the NHS was not improving. I think that's also been recently commented on, that public confidence and public highest ever recorded in 2010, but gradually diminished during that period of time through to 2020. So the question you're asking me is, if there had been no pandemic in 2024, would people be unhappy with the NHS? I suspect they would have been less happy than they had been in 2010. But I don't think things would have been as bad as they have been, as they are now, because we had a complete loss of capacity to deliver planned care for those without urgent or cancer, for example, as their diagnosis, for a period of 6, 12, nearly 18 months. And so to take that out of a system which is usually working as close to capacity as is possible, it's not possible to restore that quickly. I feel a certain sense of responsibility, particularly in my position as President of the College, to try and encourage everyone, including our fellows and members who are delivering care, and in my public communication, to say that I do think it is possible for us to restore that model. We know that it can be restored. It just will take a lot of effort and it will take some time. But the way of restoring the NHS, the position it was in prior to the pandemic, is to increase the capacity of our service to deliver for the patients who are waiting. And that will take capacity and money and resource, but it will also take leadership and willingness, and to some extent, sadly, patience.
And is that leadership both within your profession and also political?
Yes, and for all of us, and for a public understanding of the impact. It's very difficult, and when people are anxious and they know that they themselves or a family member are waiting for something to be delivered by the NHS, and that waiting number is coming down, but it's not coming down as quickly as any of us would like to see. Everybody is anxious in that time, but it's about capacity. If the service normally runs at close to full capacity, you have to create extra resource to deliver a catch-up. There is no space to deliver 6 to 18 months worth of work in a normal working week in a way that 18 months backlog can be caught up on quickly. That's just demand management, and it's impossible for that to happen. That's difficult for people to accept, and my concern, which I'm happy to express to the inquiry, is that I think I would encourage people, as I encourage our fellows and members, not to lose faith in the capacity for that to happen. It's not necessarily that the model of delivery is wrong, or the funding model is wrong, or any of the other things we sometimes hear commentators suggest. It may be that simply this is a system which doesn't yet have the capacity to deliver that catch-up.
One of the other observations you make, if I can take you back to paragraph 71 and also paragraph 74, 75 of your statement, you mention the question or the gradient of healthcare inequality.
Yeah.
And again, you say that this was heightened during COVID. Would you just explain that, please?
So health inequalities is a subject dear to my heart, Mr. Gill, but if you were to, and the inquiry may be already familiar with this from other witnesses, but Scotland has the greatest healthcare inequalities in the UK as measured by life expectancy between the richest and the poorest. So if we look at the richest end of society, they will in Scotland live for about an extra, depends which area you look at, but several years, perhaps up to 15, 16, 17 years longer in healthy life expectancy than the people in the poorest parts of society. COVID hit the poor and vulnerable harder than it did the wealthier parts of society. That's the case for almost all health situations and has been known to be the case for the last 40 or 50 years. So we know that there is a gradient of health inequality from the richest to poorest in society. That's sometimes not helped by behaviours, and there's a gradient of behaviours, and so vaccine uptake was poorest in the poorer parts of society, despite the NHS's best efforts to get to hard-to-reach communities to provide vaccination centres as close to people's homes. But and not to be unduly trite about it, my lord, but if you live in a wealthier part of my home city of Glasgow and you have a car, to drive anywhere to be vaccinated is fairly straightforward. If you live in one of our poorer peripheral housing estates and to get to a vaccination centre is a long journey by bus in the rain, you may be less likely to go.
Thank you. Final point, Mr. McKirdy, from me is to take you to your hopes for the inquiry. In paragraph 88, you make a very pointed observation about your watching of the UKI and its concentration on what you call inconsequential interactions between government ministers, advisors, and the like. And I think you recognise that that may be of political interest, and I'm sure that our colleagues in the UKI will be looking at the impacts in due course. But at the moment, am I correct in thinking that you subscribe to the view that looking at the impacts of the COVID pandemic is a useful, at least, way forward in looking to the steps that may be taken in addressing a future pandemic?
Yes, it is. I think we need to recognise none of us will know when another pandemic might occur. It was over 100 years since the previous one, and so none of us might live to see another pandemic. But I think if lessons can be learned, they will perhaps be helpful in other situations which are not a pandemic. So around collaborative working, use of IT, how we can better prepare for an emergency and have facilities and teams ready to deal with an emergency should it come along, as we had tried to do in planning for a pandemic. But we need to learn lessons from this one about how that could be done better. And I would hope for our inquiry here in Scotland that we achieve that.
Thank you. Finally, the other lesson to be learned is, I think you emphasise that there should be recognition of the huge impact that the pandemic had on the elderly.
Yes, and my understanding, I'm not an epidemiologist or virologist, but my understanding is that most infectious disease in any community happens in the young rather than the old, because the young tend to be exposed to more social interaction, their immune systems have not yet developed, and that we need to remember that in any future pandemic it may not model like the last one. And so it may be, and we need to recognise the huge impact there was on the elderly and those with comorbidities So many of the people who died who were not in an elderly age group were people who were unwell for other reasons in midlife. And we need to recognise that the next pandemic may not be like that, but therefore the generality of lessons we can learn may be as valid as the specifics of COVID-19.
Thank you very much. Mr. McKirdy, those are all the matters that I would like to discuss with you. As with all witnesses, we offer the opportunity, if there is something that you feel we haven't touched on, that you would like to mention, this is an opportunity for you to do so.
No, thank you very much, Mr. Gale. I'm content. Apologies for the typographical errors in my statement, but I'm content that otherwise it's an account I'm happy to.
Well, I'm sure we can forgive those, Mr. McKirdy, and I've at least learnt the meaning of, I think, 3 new words that I hadn't previously come across. So thank you very much, Mr. McKirdy.
Thank you, Mr. Gale. Thank you, my lord.
Hello. My thanks to you, Mr. McKirdy. I'm very grateful for your very interesting and informative evidence. Thank you.
Thank you.
Thank you, my lord.
Shall we say 3:05 for the next session?
Thank you, my lord, yes.
Now, good afternoon, Ms. Barami. Can you hear me?
Yes, my lord. Good afternoon.
Good afternoon, and good afternoon to you, Mr. Stachura.
Good afternoon.
Right, when you're ready, Ms. Barami, please proceed.
Thank you, my lord. Starting off for the record, this Mr. Sakura's witness statement is reference SCI WT 0214-501. Mr. Stachura, could you please start by telling us a bit about your own background and about Age Scotland?
Yeah, sure. So I'm currently the Associate Director for Policy Communications and External Affairs. At the time this inquiry is looking at, I was the Head of Policy Communications, a senior member of the Age Scotland team, and had a kind of a broad overview of all the work the charity was doing, understanding the insights from older people, as they were calling our national helpline, or through a myriad of other routes, and to deal with stakeholders and deal with constructively, of course, stakeholders such as the Scottish Government, the media, partner organisations, and indeed making sure that colleagues across the charity were well informed about what we were doing and how we were trying to impact the lives positively of older people. Now, Age Scotland's been Age Scotland since 2009. It is the formation of Age Concern and Help the Aged back then became Age Scotland. We're an independent charity, but we're a brand partner of Age UK, who you'll be aware of, and partners with Age Cymru and Age Northern Ireland as part of a UK-wide age network looking at improving the lives of older people, and by that we mean over the age of 50.
Thank you. Now, Age Scotland was contacted by the Scottish Government prior to the first lockdown, and they asked you to help disseminate information among the older population, and that included upscaling your national helpline to handle more calls, and for that the First Minister announced funding of £80,000 to assist with that, describing it as the fourth emergency service. How important was that early recognition, the request for assistance and the funding that was provided?
I mean, it was incredibly important for us in terms of how we thought we could support older people, but going back a couple of steps from that, it was really interesting to have that phone call from the government early March, as I recall, trying to scope out if the Scottish Government needed to provide an information service, particularly for older people, how could we do that? What were our sort of our routes? How could we potentially scale up the work they do? They have been a funder of our national helpline, or a part funder of that, for many years, so they knew its existence and what it did. But what it really helped us do was, I think, meet as much a demand from the public as possible before the sort of the first lockdown. Let's say we probably deal in the helpline with an average of 80 calls a day, for instance. But as we got into that, we were, towards 1,000 a day. 800 in the early kind of weeks was a sort of an average day. So our work with the Scottish Government was to design a service which could scale up massively from what it had been doing to take up to 1,500 phone calls from people a day. And I think what we realised over time was that our peak ability to handle calls, which is different to just answering the phone, is to have a conversation, to deal with complex inquiries. 800 or so is probably at our peak. Colleagues who were drafted in from across the charity to support this, my goodness, they were inundated with this, and incredibly difficult work for them as well.
Yeah. And did they work from home? Did you set up a virtual call centre, or did you have people come into your office?
So before the lockdown, yeah, we had to work from home. But as the helpline, once we were aware of the Scottish Government looking to support us financially, colleagues, very talented colleagues, were able to look at how we could change the nature of our helpline, which is fundamentally in an office, hardwired phones, computers, through a kind of an online database, in a sense. That part already existed, to try and move that and create a virtual call centre so colleagues could work from home or wherever they needed to be, to answer calls, to be able to use the database, to be able to communicate with colleagues too. We'd been in a slightly lucky position that probably end of 2019, we started moving towards a more flexible working approach in the organisation. You know, the introduction of certain platforms such as Microsoft Teams and other things were starting to be introduced. So we already had a tiny bit of a head start on how you might use these things, how video calls might be used or not, and how they could be properly effective in terms of internal communications. But we're able to, in a matter of a week or so, move our operation from being sort of hardwired in a room to wherever you might be. You had a VoIP connection for the phone call, that the 0800 phone number would go to you, and it would be sort of sent to whoever was available, and folks were able to handle those calls and communicate back with our database and with other colleagues.
Great, thank you. And what sort of calls was the helpline initially receiving?
At the start of the lockdown?
Yes.
Yeah, panic calls is probably how I would describe the first wave. The people not knowing what to do. They've been asked to stay at home, but actually they didn't have any food. They were running low on medication. They may have needed to see and deal with the health service. That they were completely isolated and lonely. That their mental health was suffering as a result. I think there were sort of panic calls in those early days and weeks, and trying to identify where they could go to get the support. For instance, cupboards were bare, but I've been asked to shield. I'm not allowed to kind of really go out anywhere. I'm digitally disconnected. I don't have the internet at home. I don't have any device. I don't have a mobile phone. They're using landlines to call us, and trying to find out who they speak to, because the usual routes, council offices, health service, the usual phone numbers didn't work anymore. So I think there's really were panic calls. But what do I do, and how do I eat? What can I do?
Thank you. And so they didn't have access to internet and things, so they also then, I presume, called the helpline to get updates on the restrictions and what they should be doing or shouldn't be doing. Other than the Age Scotland helpline, I understand from your statement that the main avenue for them keeping abreast of developments were the live television broadcasts each day. Those were extremely valuable for that demographic, but at one point the BBC considered moving that broadcast online, and your organisation wrote to them asking them not to do that. What would have been the consequence if those broadcasts had been moved online?
I mean, we knew from people who were calling us that they were important. Again, there's at that time, about 500,000 over 60s in Scotland went online. There are more people now that are online at that age group than there were before. But 500,000, that's about 40% or so of that age group weren't connected online. And if you consider that about 350,000 people that age group were living alone as well, there's no one else to kind of turn to do this. So the televised briefings, the sort of lunchtime regular briefings, we know from that feedback were incredibly important. It gave them that simple, up-to-date and regular information, the top-line information about what the government or the health service was asking people to do. And I think they were also important for a long period of time, not just because they were disconnected, but they became, once you're at home for a number of weeks or months, there was a routine in this. There was a sense of, heard from people, a sense of comfort in knowing that this is where they'll find out what's going on. And as we'd find from our helpline, that immediately after those briefings had ended, or towards the end of them, we'd be getting an influx of phone calls with extra questions.
Yeah.
What did this mean? What does this mean? How can I access X or Y? Whatever the new initiative was, can I do this? The First Minister's just said, whatever it is, I can travel to help care for a relative, but actually, what does that mean? So there was looking for extra clarity beyond the messages that were delivered from the government and the health service.
And you say one of the points that people were uncertain of was whether they should follow Scottish Government or UK Government guidance and directions. Why do you think that uncertainty existed? Do you think there was lack of clarity around the messaging from both governments? Or
at the beginning it was the same, if you recall, almost 4 years ago, that the messages of stay home, protect the NHS was fundamental It was the same thing. The date upon which there was a deviation, I can't remember, I don't recall. But I think it all depended on what people were watching. So, for instance, what was the first briefing that came out? Was it a Prime Minister's briefing for the evening news, for instance? They call it the next day. I suppose depending what that person's preference was, and actually trying to work out as well, does the Scottish guidance override, when it changed, a UK guidance or advice? And while they might have broadly been similar, they might have been talked about in a slightly different way as well. And even the language around, at times, as I recall, like social distancing became physical distancing at one point, so there might have been questions, or there were questions about, is that different? No, it wasn't. But actually, it's a very legitimate question. What does that mean? Is it still 2 metres? You know, and what do I have to do here? So I think there was there could have been confusion for people about, depending on their source of news, and what they were just regularly watching, what their preference was. Well, it might still been on the BBC, for instance. It might be in the kind of the UK news rather than the Scottish news that they'd have watched.
Yeah, thank you. Now, despite being asked by the Scottish Government to help disseminate information, they, even after you asked, refused to share details of updates with you ahead of the televised briefings. And you say that this made things quite challenging for you and colleagues, and you had to use your policy team to create briefings for the helpline team because there was no way the helpline team would have had time. What was the impact of this on service users and on your staff?
I mean, refused might slightly overstating it. I think it was the case that the folks that we're speaking with just weren't in a position to share this. I believe from them that there was quite a close group of people who, for instance, had sight of the First Minister's statement or further detail that's being announced, or as it's being announced, it might have been worked on. So it was more of a inability to share it than a kind of a refusal. It just wasn't in their gift to do. The difficulty then was, as I said earlier on, when people are calling you at 12:20, or whatever time it might have been, because the First Minister just announced, for instance, a programme to expand the use of digital devices to almost offer through a Connecting Scotland programme, which is looking at digital devices, digital connections, people phoning up immediately say, how do I get my free computer?
Yes.
We knew nothing more. That's one example. There'll be lots of things. But whatever the announcement was, the calls immediately looking for further clarity. And what we'd be having to do, our policy team, who are excellent at this, would be watching the briefing, taking notes, and actually trying to just translate that into something that call handlers could use. Because call handlers are dealing with calls all the time anyway. They couldn't stop what they're doing to watch the broadcast themselves, because we would still be having calls even different to the substance of the televised briefings. So making sure that people within a short period of time had a document they could refer to saying, First Minister said this. This is what we understand it means. The challenge, however, was that the Scottish Government's own website would often take hours and hours after, often the end of the sort of the working day, to have either a transcript of the briefing or indeed any further information available online. So we'd be able to kind of update for the next day's briefing further clarity, but it took an awful long time to get the answers that people needed. And if you consider the number of calls that we're receiving, our ability to maybe call people back on that as you are receiving an absolute deluge of incoming calls, inbound calls, to give them extra clarity is pretty tricky, if not impossible. So the thing I think that we often needed and felt we needed was just tell us what this information is, because people are asking immediately. And I think that demonstrated the value of having sort of offline routes for people to have a conversation, because the written communications might not have made as much sense on their own. Even if they were online, they might have gone to NHS Inform or Scottish Government's website and called us to ask us, what does this mean? How does this impact my life or the decisions I'm going to make today or tomorrow? So I think that's why it was quite important to get information as soon as possible.
And you did try to ask for it to be made available sooner after the televised briefings. What was the response, and you know, were you satisfied with that response?
No,
Did anyone offer to get permission from higher ups to share the information sooner?
No, I think we asked a few times, and there was the same kind of response at that moment. I can't remember when we stopped asking. It wasn't a regular thing, we must have this. We would often go to officials to seek clarity on whatever item it was that people have been calling about in volume, and then they would have to go off and find out what that was, but making the point that, look, someone must know what this is, could you just share this quickly, or even having it on the website that we can find ourselves. We found ourselves at times actually following the Twitter feed of the SNP's press office, who were almost live tweeting the words, the transcript, excuse me, which made it much easier to just almost to catch up and remember what was said here. You kind of had it there. I didn't really understand why the Scottish Government, for instance, couldn't do exactly the same thing.
Yeah, thank you. Now, you've just mentioned that back in 2020, more than 500,000 people over the age of 60 didn't have access to the internet, and you say in your statement about 600,000 didn't use smartphones, and there were also some who may have had devices or access to the internet, but found websites and apps too difficult to use, so were digitally excluded because of that. They were essentially left behind when there was a sudden shift to online consumption and service use interactions. You say in your statement that politicians and civil servants seem surprised by this, by the scale of it and the fact of it. Could you tell us a bit more about that?
Yes, I'm trying to recall particular instances, but the figures that I've used in this were from the Scottish Household Survey, Scottish Government's own analysis of digital use across the country. So it was Scottish Government's own figures that we would be quoting back to them. But I suppose if you consider that, you know, what is 500,000 people in a population of 5 million, you know, if 90% of people, or most people, for instance, in this room are online, and that's your universe, you think it's your kind of native, and why aren't people online? You aren't living and breathing that, then you might not have considered that to that degree. And also beyond the 500,000 people who don't have access to the internet, even if you didn't mean that you were particularly au fait with how to use it. Your limitations might be quite simply using it for social media, browsing news websites, but actually trying to navigate kind of public sector websites. I think we all might find them quite a challenge at times, councils in particular. We found GPs, practice websites really tricky. The platforms they're using and the design of them were very difficult if you were had sight loss to some degree, but even just trying to work out what to click and where to click, information not being updated quickly. And I think that in the instance we would be talking to the Scottish Government, I remember it must have been May 2020 in a Scottish Parliament inquiry, forgive me, I can't remember which committee it was, mentioning this, and actually seeing politicians, almost recalling, going, "Oh goodness, 500,000 people aren't online," and that would be the equivalent population of Edinburgh, for instance. So it's not a small number of people. But again, those with smartphones, it's a different degree of what that smartphone can do. So, download this app or scan this QR code. You're asking people to do things which most of us who do this on a regular basis would be quite comfortable with, but you've sort of missed a beat in trying to explain what a QR code is, how you access that, what it's going to do, and actually people a bit nervous about where they're going on the internet. Where is this thing? And trusting the data, trusting the information that's being passed around. I think they are legitimate concerns that people have about using the internet or using digital devices. But I think the vast scale of those that just didn't have it was at every occasion you almost had to remind officials or politicians that the scale of digital exclusion in Scotland, just for older people, and there's more beyond that. If you're on lower income, if you're disabled, lots of different types of people who wouldn't have access. So that was just on looking at people over the age of 60, and just looking at 50, it'd be even more. So I think that's something that took people back. That the only option we had apparently was a digital route, and therefore, if it worked for the majority, then that will just have to be what it is. Okay. And I don't think that really landed particularly well with those who were probably more likely to need support, need services, but had no way of accessing it.
So nobody, as a result of that being highlighted to them, thought, let's take things a step back and make telephone access a possibility again. They just said that that was, there was nothing that could be done.
To the credit of the Scottish Government, they quite quickly set up, I referred to earlier on, a Connecting Scotland, which was about kind of proliferation of digital devices, whether it's tablets, I believe, or laptops.
Yes.
And the first phase of this, I think from May until June, was looking at older people and using intermediary organisations to almost identify who might be needing them and how to kind of access that. It was quite a low number of people in the end who'd get something compared to the kind of the need. But I think in terms of public services, and it'd be why the Scottish Government had asked us to expand a free phone helpline. You call up, you're not dialing 1 to get through to person X or 2 for person Y. It was straight through, someone would triage and move on. But you would be calling up local authorities and it would go nowhere because actually there was no one to answer the phone. There wasn't a system in place. And calling the health services, even a GP practice, should be referred to on the answer machine to consult NHS Inform. So you'd be phoning up, actually asked to go and find out more about your condition or your concern on a website. So and you can understand to a degree if that was the only option in an emergency. But I think the challenge for public services that people rely on is that over time there didn't seem to be any impetus to revert back to the things that people clearly needed, or that this is working fine as we are. And I think now we look at it ourselves in 2024 that services are predominantly there. We're moving to digital-only everything, and it works for lots of people, but we've completely forgotten those who just aren't able to, and it's not just about older age.
Yes.
But I think this is why, looking across the period that the inquiry is interested in, that we never saw any return to telephones, to face-to-face, to paper copies of things that people needed. That just wasn't possible, and the longer it went on, it just became the norm.
Yes.
And it kind of institutionalised this remote access to the public.
Yeah. And you mentioned Connecting Scotland there, and you also mentioned that in your statement that as well as devices, they provided data packages to older people. So that helps improve digital exclusion for those that simply don't have the facilities. Did they take any steps to help those that were digitally excluded by virtue of a lack of sufficient technical knowledge or ability?
As I understand, yes. I believe the package of support for individuals wasn't just you'll be shipped off a device or a kind of a data like SIM card, for instance, if it was an iPad or whatever. But there was a connection made with someone who could support you. Now, a lot of this obviously had to be remote. You could go and see somebody face to face, or somebody sit in your living room with you. I can't recall the exact detail of how that worked for everybody, but I think the aim in the early stages was to use, intermediary charities, for instance, who had their own networks to how they would support people, and kind of left to them to best do it. I might be mistaken on all of the detail, but as I recall at the time, it was it's setting up something from nothing.
Yeah.
But I think the way that people feel more comfortable with it, for instance, saying somebody, okay, now you've got this, go to YouTube and find out more. Okay, what's YouTube? Now, it's about that kind of retranslation. So I think there is a broader piece here as well about how the reliance on people just to know what you're talking about is sort of a bit of a fool's errand at times. But yeah, I'm sure the system worked better than I recall for those that were accessing it. But I think the gulf between, I think the funding pot was for about £30 million, potentially help 30,000 people across Scotland to do this. So while that's a big project, it was, I think, a drop in the ocean in terms of what the need was.
Yeah. So the lack of resources made it less effective than it maybe would have been otherwise if. Well,
I think there's probably a lot of resource. I mean, £30 million is a lot of money, but how you actually managed to do that, I think, was very, very challenging. So there's no real criticism of that. I just think that there were different phases, for instance. So if we're looking at older people, the first phase was for older people. It moved on, I think, in that summer to families and with children, maybe looking at those who are out of school and how to connect them. And maybe a year later, I think older people are back in as a phase. But so I think the first phase probably had the lowest impact. I recall trying to find figures, the number of people who had been supported, and it was really difficult to find, like how many older people actually got a device, had been supported, and particularly against everyone who was supported. But there was definitely recognition that older people were more likely to be digitally connected, disconnected, who would require support, so they were the first phase. But it's quite hard to demonstrate, in terms of my own eyes, the impact that's had for the whole population who are disconnected.
Thank you. Now, you've mentioned and you say in your statement that it was impossible for many older people to order groceries and other necessities online because they were digitally excluded, and this led to food insecurity for many. But you say that Morrison's, the supermarket, accepted telephone orders and payments, and then subsequently you and other third sector organisations wrote to the government and to major retailers asking them to step in and work together. How did that go? What was the response?
The origin of this was a phone call or a message I had from Which, the consumer organisation charity, forgive me for maybe getting their definition wrong, somebody there that I knew and know, who wanted to highlight they were seeing some significant challenges across the folks that they were, hearing from about access to food, and had we heard similar things? And of course we had from day one, particularly for those that weren't online, that couldn't, the only route to order, online groceries was online, and there were very few delivery slots available as well. So if you were shielding, for instance, that was the route. And Morrison's, I think they did a good job. I can't remember the criteria, but there was an option to call up to give them your order, to pay over the phone, and it would be delivered to you. So the conversation with Which turned into us looking at, okay, who else has an issue here? And there was a range of organisations and charities that, from their constituent groups, were having problems too with accessing supermarkets. Even sight loss charities, as you can imagine, with social distancing or physical distancing, made it very, very difficult to be in a supermarket. And so we ended up getting together, thinking about who is it in the Scottish Government that we could speak to identify, like, here is a problem from this constituent group of people who are really struggling to access food, who are relying on neighbours, who are relying on other local action groups or community organisations to do this. But for those who are completely isolated themselves, whether they just aren't connected, they might be in a street of 100 other houses, but completely isolated from everyone else around them, how can they, if they're not online, get access to this? So we ended up writing to the Scottish Government to just make the case for more action, to expand it was government and supermarkets, the major kind of food retailers, to expand the availability of deliveries, of having some kind of priority system for those that we felt were kind of most excluded. Otherwise it couldn't get to shops themselves by virtue of being shielding or their own mobility or their location. So for instance, if you're in rural parts of Scotland, there might not be a supermarket network available to you. So I think life looked very different depending on where you were. But as part of this, we're just desperately trying to find out who in the Scottish Government is in charge of this. And the sort of intelligence, I think, from Which was that DEFRA, the UK Department for Environment and Food, they were sort of coordinating UK-wide things. So not really sure if there was a separate sort of Scottish action on this. So I think what I'm really trying to say is it was quite hard to work out who to go to. And even asking people, the government officials weren't entirely sure at the time. So it wasn't that we're just trying to find out ourselves. We generally asked, like, who do we speak to, trying to get some action to improve the situation as quickly as we possibly could. And there was certainly an appetite from the retailers to do this. And I think they were really trying to find out how they scale up their operations. When a lockdown moves from 2 weeks to 2 months or whatever, they've realised we must must do more. How do you get more vans? How do you kind of increase your kind of your packing of food and getting out? So that was a tricky time. I don't think we ever really got a particularly satisfactory kind of answer from the government, whether or not that we were, a necessary kind of vehicle for them. They wanted to make sure, at the very least, they had information about who was being left behind here, the impact on their lives, and my goodness, can you think about how to improve this and pretty quick, please. But that was the origin story and kind of the reason for doing this. But it was certainly something that came through different surveys that we all did with our constituent groups, the feedback we had from our helpline on a regular basis. But it really demonstrated a incredibly pressing need to fix this, because people will get very ill or die without any food.
Yes.
And it'd be a lot of people who's really struggling where to go.
Thank you. And people who contacted your helpline were also helped by Age Scotland to get in contact with local organisations who might be able to help them. Is that correct?
Yeah, we had colleagues who were sort of tasked with working at what was happening across the country, almost building a list of community groups, resilience groups, local organisations and charities who were essentially doing food deliveries themselves, that they were doing shopping orders. So if somebody called us up, we could sort of refer them in or signpost them to somebody else local to them who can help. What we weren't really geared up to do ourselves was to do that, but we did have colleagues at times who there was no other option, and I understand some people at times just got in their cars and took food to some people. I mean, I think it wasn't the norm, but because often there were really great local answers, but kind of collating that information in a hurry, and those early days and weeks was, I think, a big challenge for colleagues, but I think they did a really good job. I think helpline advisors and call handlers had a good list across the country of who you could call. What we didn't have any real sight of was how effective that was for them, but I think we were quite reassured by the conversation we have with these groups that they were able to meet those needs. Because I think what we found from the pandemic was individuals, wherever they live, just wanted to do something. You're asked to be at home and actually trying to organise yourself to something that's effective, rather than just being at home watching the TV and hearing dreadful news every single day. People wanted to take action. So that kind of self-organisation across the country was incredibly effective, and I think really filled an incredible gap before sort of local authority resilience committee work happened, which were to deliver food parcels or to support people on the shielding list, because that might have taken a number of weeks to happen. But local organisations jumped in and were able to identify who they were in most places across the country.
And the local authority food packages that you mentioned there was an issue with them not catering to dietary requirements. Did Age Scotland raise that issue with local authorities?
I'm trying to remember exactly how we did, but we certainly will have through whatever routes we had at the time. As mentioned before, it's often quite difficult to get in contact with anyone in local authorities, and our main route into the government was through a team of officials in the Equalities Department who were really very responsive and helped kind of share information that we had through government, as we understood. I'm fairly sure that we made that clear in a different piece of correspondence with the Scottish Government or ministers on, how people were coping with the kind of the lack of sort of suitable food. I think it was particularly important for people from ethnic minority communities who would be vegetarian, but there were items in food parcels that would contain meat. And obviously the number of items in the parcel was quite restricted. Wasn't, if you didn't eat that, you didn't have anything else. Also real kind of consideration for dietary requirements. So whether someone just doesn't, as a diet, eat pasta, for instance, but actually maybe lentils or other things, which are really, really important. And I don't think that was a luxury, but I do know that there were organisations who were able to get funding from the Scottish Government to kind of work on their own initiatives to get kind of more sort of sensitive foodstuffs to the people that they knew in their own networks. I think that was incredibly effective, but I think the early stages of sort of packing boxes of a variety of things might not always have been it didn't work for everybody all the time. And I think when food parcels arrived that were necessary, and finding that a number of items just weren't suitable, you're doing a bit more self-rationing on, which are already, I think, quite limited supplies of what you could eat. I don't think there was a really effective way of trying to get replacements. That's my recollection of, at this point it would have been 4 years ago.
Now, another consequence of the lockdown restrictions was that almost all social care packages ended. What were the consequences of that, and did Age Scotland try to raise the issue with the Scottish Government?
This was really quite harrowing. There were phone calls in mid to late March 2020 from people in different local authorities. As I recall, some particular challenges in Glasgow, Falkirk, and there's another one. I don't want to name them in case it was wrong, where the social care package at home, in their own home, they were told by those delivering the care package. Glasgow, for instance, I think social care was outsourced to a company called Cordia, and by virtue of lockdown restrictions or social distancing or people being kind of vulnerable themselves, wouldn't have had enough social care staff to do this, but people were told with a day's notice, up to 4 days notice, that your care package will completely stop. You could no longer do this, and there'll be people who were relying on carers for medication, for showering, for food, for all the types of things which are absolutely essential for someone to live independently in their own home, were turned off overnight. And I think for a lot of people, it would have taken months for that to return. And even once things returned, the care packages that were delivered were sort of to a lesser degree than they would have had initially assessed for. But the challenges for people here was that they were sort of told that, well, you have family that live nearby. It was quite subjective. Within, I think, 30 miles, some places said, they have to do this. They either have to do this. But actually what we're getting from the families was, actually we can't, because we've been asked to shield. We'd love to. I'm actually clinically vulnerable myself. There's somebody in the household who has COVID-19, so I can't leave, and I certainly don't want to give this to my loved one in their own home, because this will be catastrophic for them. So I think there were very legitimate, fair, and strong reasons why the kind of alternative, which seemed to be just sort of rustled up, that okay, you've got someone who lives close to you, will do this, but actually the reality was very different. So people will have gone without, and I think the impact on people's lives there, without that social care package, even for a few days, never mind weeks, will have been very severe on their health, and undoubtedly resulted in needing medical attention, medical care, as opposed to social care to kind of sustain their quality of life. And actually, I'm very sure, sadly, that will have resulted in some of the excess deaths that we experienced in that first year, beyond kind of just COVID-related issues too. So very severe consequences, but this was a common theme across the country. The packages just turned off, very little notice, and not really anywhere to go. I think the phone numbers that were available to call local authorities to almost appeal them would go to the same people who have decided that the package has to stop. So there wasn't really any appeal process or any obvious way upon which a resolution could be found. I remember that we did make the Scottish Government aware of this immediately, but never really heard of an answer, because actually at that point it just started to proliferate in terms of who was experiencing this and where they're experiencing this. So it might have been something that they couldn't possibly do anything about.
And following on from that, because you mentioned they would then need medical treatment, and more people potentially died that wouldn't have otherwise. Another big impact on older people was the suspension of routine screenings, and the consequent backlog when the services reopened also meant there were delays. What was the consequence of that in terms of health and life expectancy as well?
I mean, some of that will be speculation on my part in terms of the consequences, of course. But I think going back to some facts on this, I remember insight from our helpline about people who are calling who are over the age of 70 about breast cancer screening. Now, before then, I think you could self-refer. Previous witness here was talking about, I know between people aged of 50 and 70 are invited to go on a sort of a 3-year cycle for breast cancer screen, for instance. But we were particularly concerned about people who were no longer able to sort of self-refer, even those who felt they might have been at risk of this or had survived cancer in the past, and sort of exploring what happens here, when will this reopen, when does this, it was impossible to find out. And actually speaking to some cancer charities at the time, just trying to find out from them, as they'll be experts in this, and if we weren't, but hearing from people about, real concerns about their own lives or the kind of the access to health that they felt they were entitled to or wanted, because there wasn't really a date for resuming this. It just was at some point in the future, but that was so vague. People were really concerned. There was concerns from some of the cancer charities about this as well, sort of from them to us. Well, actually, the older you get, you might be more at risk of cancer, and they were concerned through us, and wanting us to almost kind of push on a little bit with the government about trying to agitate for kind of a solution. It'd be one of many things, of course, and I think with an emergency situation we're in, but this would have been late 2020, so it wasn't just in the first few weeks. It was that as people start to realise what they couldn't do anymore, what they couldn't get access to, we would get phone calls about this at different times. This particular instance wouldn't have been in any kind of wave, but just you'd have instances that you just felt were wrong, or that people weren't getting, satisfactory answers, or feeling reassured that their health concerns would be met at any point. So I think that's where the kind of screening is an example of this. But that's really stuck in my mind from that time, and actually even from a personal experience of family members who've been in this position and thinking about them if they needed this. I think that kind of is a theme for lots of families, I'm very sure, about the impact of kind of health conditions and actually how they couldn't get sort of even early diagnosis. And there will have been, and I know of people who have died of cancers, diagnosed incredibly late, and had a very, very short time after that diagnosis, and people who themselves knew that they weren't well. They had been nurses in the past. They knew that something was wrong, but they couldn't get a diagnosis, couldn't get any kind of treatment, and have really desperately, sadly died well before their time. And I think that's something which sort of struck, in terms of our evidence and issues that we wanted to raise. These are things that struck colleagues across the charity about insight from older people and access to healthcare.
Thank you. I'd like to move on to the issue of DNA CPR decisions. From the end of March 2020 throughout April, you say that Age Scotland received many calls from people who said they'd been contacted out of the blue by their GP, and even in some cases by the surgery receptionist, to see if they would agree to a DNA CPR decision being put on their medical records. Were all of these people in poor health, and people for whom a DNA CPR decision, as far as you know, would have been clinically appropriate?
A lot of the conversations that our helpline had with people, it was because they're absolutely taken aback about why on earth are they being phoned about something now, and it's never been mentioned by their GP or in the health service before. This, again, you're looking at early April, probably the height of when we sort of saw a trend. Before that, I don't think our helpline would have ever received an inquiry about a DNA CPR decision or looking for information or advice about that. On a regular basis, people would be quite forthcoming about their own kind of health and say, actually, I'm in good health. I might have something like COPD, but it's mild. But all of a sudden, I've been asked to agree. Initially, it was agree to a DNA CPR decision, of which they would say, well, no, because what does this mean? You've told me nothing else, and at times it wasn't even a clinician, as you said. Would call up. It would be the receptionist or admin staff or GP practice saying we're making these calls. There might have been a kind of some kind of introductory conversation about how are you feeling? And then on some occasions it would move into, how would your husband cope if you weren't here? And then moving on to, have you considered DNA CPR? Now that, or do not resuscitate decision, now that out of the blue with no context, actually, so the calls we'd be getting asking, what on earth is a DNA CPR, or a DNR, or a DNAR, depending on how it was being described. And I think this is one of the most chilling parts of that early part of the pandemic for us, was the scale of calls. I can't quantify it, because actually the beginning, we weren't logging them as such. We didn't necessarily have a kind of a particular code for that, and we're sort of huge numbers of calls and trying to kind of handle, as opposed to logging every case very prescriptively. But it was a common issue from all of our helpline call handlers, and there were particular moments, probably beginning of April, those calls started happening, and would continue. We would receive calls with us throughout that month into May for sure in terms of volume of calls. But it just felt from people's experiences that they've been written off. It's their words. Their words. Incredibly anxious, but what does this actually mean? Why are they calling me? And there was one example of many, I'm sure, of a woman who had been called about this and asked to agree to such a thing, who had said no to it. She'd noted that she was on a shielding list herself, had received a letter about that 2 weeks earlier, and asked, do they need to speak to her husband as well? But he's not on the shielding list, and they said, no, we don't need to speak to him. Similar age, similar kind of health conditions. I remember there was a particular example of a woman in her late 50s who was a runner, and I think her only health condition was hearing loss, but was asked about it. And there's a range of issues and a range of conditions which you feel would not preclude you from having your heart restarted or your breathing restarted if they stopped. I think that was a part of it, and I could go on for weeks about the type of calls that we had, but I remember being contacted by a woman who, it must have been her granddad, he was a 101-year-old veteran living in Glasgow, who one day got a knock at the door from paramedic and was handed a bit of paper, and they told him, just keep this by your bed. And he dutifully said, yes, of course. And she'd gone round to visit. This was later on in the year, and found it was a do not attempt resuscitation form, and under the reason for, it just said communication difficulties. And that's because he had hearing loss. And I think that in itself, there was no logic to this, and why you have to keep this by your bed. So if a paramedic, arrived and saw this, to what degree would this mean that you maybe didn't get the necessary treatment, never mind kind of resuscitation? So again, really chilling examples of how this is applied to people in quite a cavalier way at times. And the examples in care homes, where a whole care home would be sort of every single resident would have been issued or a DNR decision made in their name as a sort of blanket decision, but with no real individual clinical assessment of folks.
You touched on it there. Did you find that a lot of people thought that the existence of such a decision on their file would impact medical treatment beyond CPR? That
was what people said, and that they felt. Now, whether or not that, on a strictly practical basis, a DNA CPR decision is just about resuscitating you if your heart stopped or your breathing stopped.
Yes.
However, the instances upon which we would hear from people about the treatment, the medical treatment they were receiving or didn't receive, at the same time as being asked repeatedly to agree to a DNA CPR, and them saying no, and then finding such a thing in place and maybe not having access to the treatment they required, was quite difficult to hear. So I do understand the importance of DNA CPR and anticipatory care planning. It's an important piece, so people can make decisions. As much as a clinician, you have the right to decide how you want to be treated. But again, clinicians can make this decision unilaterally. But there'll be occasions where people would find forms in discharge papers from hospital, and the box would be ticked which said conversation had with patient, or the equivalent thing, and that never happened, or a name written in where someone just kind of a sign. And I don't think that was necessarily a standard practice for a form, but I've seen examples of this, and those conversations never happened.
If somebody were to suggest that clinicians were having these conversations, but through the stress and trauma at the time, people were forgetting, do you think that could be the case?
I really don't know. I think there'll be occasions, as we find from our own insights, that people who are maybe in hospital, for instance, who are suffering from delirium, who a conversation was had with them, and would have been inappropriate, I think, in any measure for them to have had a reasonable answer about agreeing such thing. Well, obviously, with the caveat that they don't need to agree, but part of the whole DNA CPR process is to have a good conversation with somebody, for clinicians to have a kind of a good, well-informed, respectful decision about kind of end-of-life decisions. And I think there is far too many occasions that we heard of, and a range of other charities and organisations that might, whose are constituent groups are people potentially more vulnerable to different kind of health conditions, who have been in this position, that it was sort of forced upon them out of the blue, and I've used that again, and the anxiety that people had about what does this mean to my access to health and care if I needed it. And there are examples of, being sort of quoted, whether it's in news stories or in television news pieces of people, real life examples of this, whether or not, a case in Edinburgh where an older woman had been asked repeatedly about signing up or agreeing to DNA CPR. She died the next morning because the oxygen hadn't been connected. There was ongoing issues there, and there were particular medical kind of complaints about their treatment, but this wasn't on its own. And I think when you spoke to other organisations about this, they were getting exactly the same concerns from people, but also anxieties about a lack of medical treatment that might otherwise have been available to them, but because a DNA CPR being discussed, it felt like all their medical options were shut down. And even on discussions we had with clinicians through Healthcare Improvement Scotland in 2021, as I recall, they recognised that they haven't been particularly good at having these discussions. So your point about, under the stress of dealing with all this, I'm sure, that's a particular challenge of trying to work out how to deal with so many patients, or how to manage a crisis in a health service. But I think there's a recognition from clinicians that they just hadn't been particularly good at having good conversations, and that the practice around decisions being made it fell short of what they would expect to happen, irrespective of a crisis in the health service.
Thank you. In your statement, you say that it was a scandal that people were being written off, and you've used the phrase written off in your evidence today as well. And you say that you contacted the Scottish Government about this, and they denied asking GPs to start doing this. And at a broader meeting with the Scottish Government, you raised the issue of misuse of DNA CPR decisions, and a policy officer vigorously denied the issue because they said nobody was contacting the government about it, and they couldn't seem to grasp the reality of the situation. On the issue of people contacting the government, in your experience of speaking to service users, do you think they could have easily contacted in the Scottish Government, someone in the government, to raise this issue?
At that particular meeting, I had no idea the routes upon which they expected people were contacting the government. Was it through an online form, by email or otherwise, and to what degree could they collate all of this? It really wasn't clear what at that moment, those routes were. That particular meeting is clear in my mind. A video call that we'd had, and it was just this flat denial that there was a problem. There was a flat denial that anybody was getting phone calls from GPs about trying to agree to DNA CPR, and the answer was, well, clinicians can do this anyway. But just wholly, despite the evidence, without the volume of phone calls, couldn't fathom that this was actually happening. Not about anything behind the DNSCPR, but that people were getting these phone calls and the volumes that they were. It was a source of huge frustration, and actually meant that we couldn't go any further forward with this. So we'd written to, I think Jean Freeman at one point. We'd gone through different government ministers. We'd written to the Health and Sport Committee in the Scottish Parliament at the end of that year, asking for an investigation into this. We had eventually concluded that Healthcare Improvement Scotland might have been the best place to go to look for an investigation, but actually it was completely, it didn't seem to figure in people's minds that this was happening, the scale it was happening, or indeed trying to kind of comprehend the impact that's having on people and how that potentially was affecting their kind of access to health treatment. And there was another example towards the end of, I think it was 2022. We had a national conference, H Scotland's national conference, and Jason Leach, the then still clinical director, was a sort of guest speaker at this as a Q&A with older people. But it was an online forum. It was filmed, live streamed, and the question came in from the chair about DNA CPR, and he had said, and it's available publicly still, that there wasn't, some of it wasn't an issue. People hadn't been kind of asked to call people about it, and the kind of the chat function just was set alight with people saying, well, this happened to me, this happened to me. I think he was slightly taken aback by that as well in terms of his own understanding of what was maybe going on. I don't mean to say that he didn't know what was going on, of course, but I was in the room at the time, remember, to sort of seeing the impact of that people who we hadn't been in contact before with this were saying, well, so the scale of this was greater potentially than we had thought. But I think it was just this absolute lack of recognition that this was a thing.
Did anyone in the Scottish Government at any point ever take ownership of the issue and try to make, even if they say the instructions didn't come from them, take ownership and attempt to contact GPs or their representative bodies to tell them to stop the practice?
So actually, in April, towards the end of April, middle to end of April, I understand that after these conversations with Scottish Government in different fora, Jean Freeman, the Health Secretary at the time, and Gregor Smith as Deputy Chief Medical Officer, had, I think, written to GPs to make clear that there is absolutely no need to preemptively phone people or contact people about, a DNAR decision. The government had denied that there had been any communication about this to GPs or in a medical setting before that moment, which we'll absolutely take it at its face value. But there was an action taken in April to GPs and all the medical settings to either stop doing this or there is no need to do this. But after that, it was really hard because I think what we wanted to find out was the scale of this. How it had changed than the year before the pandemic. What the origin of these calls, these highly distressing phone calls, and just what could people do to find out if there was such a thing in their name, which might have an impact on their healthcare in the future. So, for instance, if there was in your medical records a DNA CPR and you wish to have resuscitation attempts, but there was a slip essentially in your records, then that wouldn't be attempted, because they might be believed that was your choice. But a clinical setting, you might actually survive. So I think there's some worrying practice in terms of what exists in people's records.
Yeah, and you tried to
Ms. Barami, you're just over 15 minutes to go.
Thank you, my lord. Now, you tried to get information about this from the health boards as well through Freedom of Information requests, but you were told that they don't have the figures because there's no central database, it's just bits of paper on files. Did Age Scotland consider that an acceptable position? Does Age Scotland believe there should be centrally stored numbers?
As part of our own scoping exercise, because we've been asking, people to investigate this. We wondered what information was out there. If no one else was willing, government or Parliament or anyone else, health service, to investigate the scale of this, what could we find ourselves? And yeah, I think there was one health board, it might be Forth Valley, that had a response, and it was a very low figure, because one of the questions was not just the number of DNA CPRs in a certain time period, but how did that compare to the same time period the year before? I think we might be looking at March to June 2020 compared to March to June 2019, and the figures looked very similar, which didn't seem to compute compared to the calls we were getting or the type of thing. But every other health board either responded and said they didn't have this information or it wasn't possible to obtain. And I believe from speaking to one or two of the health boards, it was because these are bits of paper, they weren't necessarily logged anywhere else, but then you sort of find out there are other routes that these are, logged, whether it's through, I think it's something called SIPS, some kind of like patient information system, or that the paramedics have and ambulances have, which presumably if you arrive at someone's home and you'll know a little bit more about them. But it was really difficult to find this. I don't think it was an acceptable position to not know the scale of this. I think the health boards should be pretty interested in clinical decisions made, and how that changes over time, and the reasons why. But it feels quite antiquated in terms of, in this instance, in terms of how patients, individual citizens, human beings, have any kind of decision making or control of the information that's about them. So I think that was a worry in terms of what do health boards know about what's going on, and it's probably speculation, but it's never been in any volume before at that moment. But it was clear from all the discussions we're having that no one was really willing to take ownership in finding out any more. Positive discussions with Healthcare Improvement Scotland were about the future, how to reform the system to make education better, both for clinicians and for patients, to improve conversations, to make people more aware of advanced care planning, essentially. And that was a positive step for the future, but there was no, I think, ability for anybody to look back, which is why we're incredibly keen that this inquiry, when we've been calling for it since early 2021, and discussions with John Swinney at the time, was that the NECPR was in your terms of reference, because it was such an important issue at the time, not just for us and for older people contacting us, but across a range of different citizens in Scotland.
Yes, thank you. And you say that in your statement that Healthcare Improvement Scotland said they lack the power to investigate, and they had a roundtable discussion with you instead, and you've described the outcome of that. But you'd also asked the Scottish Parliament's Health and Sport Committee at the end of 2020 to conduct an investigation, but they told you that they didn't have time within that parliamentary year to do so, and they didn't seem able to carry out an investigation in a future year. Is that correct?
No, that's absolutely correct. And I think that's probably, in reflection, a reasonable response from the Health and Sport Committee at the time, because it was November, I believe, 2020 election would have been, or sort of Parliament would have stopped operating sort of mid to end of March. They'll have a schedule. I'm pretty sure we wrote to the equivalent committee after the election as well about this. But I'd been in at least one parliamentary inquiry between May and November 2020, and we're talking about DNE-CPR and making the case that, what had been happening, what we'd been hearing from people, and it was an unacceptable practice, and felt quite angry about how people felt they'd been treated, and that there was not really any information or any kind of recourse to information or understanding about what has happened and why it's happened. So that kind of call for an investigation into it was a regular occurrence, but nobody was able to, either felt they were capable of doing it or had the time to do it. I think that's a great disappointment, because we'll have moved on so far, and I think actually getting that right information will be a difficult task to do. I don't envy your job here.
Thank you. I want to move on briefly to ask you a couple of questions about care homes. Now, we've heard a lot about the issues faced by families and other organisations, so I am just limiting it to a couple of points. But you raised the issue of essentially remaining alive versus actually living. Am I correct in understanding that Age Scotland's position is that more value should have been placed on quality of life and making the final weeks, months, days of people's lives enjoyable rather than potentially extending the duration of life at the expense of quality and quality time with loved ones?
No, absolutely. The beginning of the pandemic, it was an interesting split in types of calls from concerned family members about care homes locking their doors. Some people, particularly for a short period of time, believing that, okay, understand this, it will keep my loved ones safe. But as time went on, you know, week 3, 4, 5, month 2, 3, 4, 5, and the doors weren't still open, that visiting was so restricted that it was clear, it was so obvious that the quality of life for residents had diminished to a great extent, that people had their conditions had got worse, that they weren't the same person they were just a number of weeks beforehand. There's a rapid decline in their health, and for us, and we're on a regular basis made that point to the Scottish Government, behind the scenes and behind the doors in media statements, that we need to make sure that care homes have everything they possibly need to support visiting, and it can't just be a phone call or a video call or something through a window or in a garden. And I think the distress that you'd hear from residents and their families about the quality of life, that in itself is harrowing, and that I think a lot of people have died a lot sooner than they otherwise would have, or became a lot more ill than they would have, because of that absolute isolation. And the examples where people didn't have their personal belongings in rooms, and lots of things around this, I think were wholly wrong. And it just has taken us far too long to, as a country or in any kind of institution, to properly support that. I think there was evidence out there how to do it well, but it was very disjointed. I just don't think that, you know, care homes or social care got anywhere near the support that they needed from health or from government to treat this as a priority. And it's still going on today, of course. That care homes won't be open for different reasons, for infection control reasons. But my goodness, we might not have been as vocal all the time as we could have. But I think the defence that at times there were lots of different issues that were going on. But in a regular occurrence of the government or in media statements, we were very keen for care home visiting to be supported.
Yeah.
Yeah.
And you actually, the other point I wanted to touch on was in relation to that. You state that care staff and other contractors have been acknowledged as being the carriers of COVID into care homes, and on that basis, you think on balance, you think on balance that it would have been more beneficial to support care homes to have adequate PPE and testing in place so that families could assist with their loved ones' care. Did you raise that with relevant authorities, and what was the response that you got?
I mean, this was I think the context behind the sort of carriers of COVID were that you have people just coming in to a care home wherever they're from. Now, necessary, critical staff coming in, but they weren't in isolation, so potentially could be carrying a virus, you know, asymptomatically or otherwise. But why couldn't other key people, whether it was a designated visitor, a key family member, do the same and actually be under probably stricter conditions, potentially with testing before they went in, having really appropriate PPE? And so these conversations were had very early, certainly in April, and about, first of all, the lack of PPE availability for care homes in general. I mean, real anger about this. You know, there was this is certainly early April conversations, and sort of hearing from the care sector about these didn't have anything. People were going on eBay to try and find anything they possibly could, but never got to the point where they had enough. But with regard to visitors, I think there's an appetite from family members to do everything necessary, everything the safest possible way to make sure that the loved one, as best you could, and on balance, not contract COVID-19 or some other illness from you. So going in with, you know, properly kind of sanitized, having maybe a rapid test before you went in, you know, making sure you've had some kind of isolation from others for a period of time before you went. And I know from people there was an appetite to do that, but it just wasn't ever supported, and there was really good, I think, internationally recognised standards for infection protection and control that could be utilised there, just weren't ever consistently or at all implemented by public health. And that kind of the landscape of hundreds and hundreds of care homes, they all look very different, and how kind of they function and how they kind of the buildings themselves. You'd probably have quite a unique job for each of them, but I don't think that would be impossible to do. I just don't think there was enough effort there, and the longer it went on, it just seemed to drift, and no one's taking responsibility. So how do we make care home visiting possible, as opposed to it's a risk, we can't do it? I think there was it should have been a differently framed question, and someone tasked with making it possible to happen, because people, the end of their life will have been poor. I don't think that is something any of us would want for ourselves or for loved ones.
Thank you. Is there anything we haven't touched on today that you would like to add at this point?
I don't think there's anything beyond the statement or the other written documents that have come in.
Okay, thank you very much.
Yes, indeed. Thank you, Mr. Stachura. That's all for the day. Now, we're, for a variety of reasons, not sitting until, believe it or not, 3 o'clock tomorrow afternoon. So, 3 o'clock tomorrow afternoon. Thank you all.
Thank you.